Hello and welcome to week 5. Isn't that amazing? And remember, this class is only 8 weeks long. So we're moving into the second half of the PCS book. And I thought we would talk about imaging. So, at this point, you have learned how to uh, build your code one character at a time. And yes, it's very different from diagnosis coding, very different from CPT coding. So it's important that you use your coding manual because everything you need to know is right in there. Okay, all the definitions of the root operation terms, all the definitions of the body parts and the devices and the approaches and all of that kind of stuff is right there in your coding manual. All you have to do is turn the page. And it is very, very important for you to use your resources. Now, before I continue, I want to tell you that we are going to go over one case study, but it covers 4 screens, 4 slides. So if you don't have a writing implement, a pen or a pencil, and something to write upon, such as paper or into your phone, whatever makes you comfortable and happy, that's fine. But you will need to take notes as we go through. And then just to give you the heads up, there are multiple codes that we're going to be doing for this one case study. So I want you to be able to take notes as we go through. And of course, if you want me to go back, I'm happy to do that. Okay. So while you're getting your paper and your pen or whatever, it is very important that you understand that all 3 codes, actually 4, if you include HICPICS level 2, are very different from each other. And you cannot cookie cutter your methodology from one to the other. Okay, so as you go through this and you're learning this, focus on what was done for the patient. That is your definition of a procedure code, right? In addition to that, I want you to, as I just said, and I'm going to say it 1,000 times until it's so part of your brain you can't even get rid of it. And that is, you have to use your resources that are right there inside your coding manual. You already have it. There's nowhere to go, nothing extra to buy. It's all right there. Okay. And that is going to help you be more accurate. And remember, we talked about tabbing. Let me show you tabbing. Did I tab this? I haven't. Yes, I did tab this book. Okay. Here is the brand new 2022 book. And you can see how I use my tabs to be able to go back and forth using the different sections of the code book. Okay. All right. So you have your paper and your pen or other ways of taking notes. And this is very important. This is important for you to do in the real world. And by the way, when you are sitting for the national certification exam, you will be able to take notes as you go through case studies. Okay. All right. So here we go. The patient is Scott Pepper. Diagnosis on admission, malignant infusion, dyspnea. Remember medical terminology. Dyspnea is difficulty breathing. History of metastatic bone cancer, bone disease. Oh, that's sad. Small cell carcinoma of the lung and hepatic metastases. Remember hepatic from medical terminology, the liver. So that means it went from his bones to his lung to his liver, or from his lung to his bones and then his liver. This guy is sick. I'm sad. Okay, chief complaint. This 71-year-old white male was admitted for evaluation and management of his rather large right-sided pleural effusion. Remember, right side is always going to be the side of the patient, okay? The right-sided pleural effusion and dyspnea. He has had somewhat of a dry cough. He has had somewhat of a scattered bone pain syndrome. He denies fevers, chills, or sweats. Okay? You got the handle on why he's here. And obviously he's an inpatient. He was admitted. He's an inpatient. Okay. Past medical surgical history, see progress notes of Dr. Hammond, now part of this record, October 23rd, 2012. Medications at home, he was on Prilosec to Norman, Hitrin, digoxin, and Megrase. Allergies, he's allergic to iodine dye. Very important, because remember, we are today reporting for the imaging. Social history, non-contributory. Family history, non-contributory. Review of systems, non-contributory. Pulmonary effusion. BP, blood pressure, 140/70. It's a high. Okay, pulse 80 and regular, respiration 20, slightly labored, and he has a temperature of 98.6. His head negative for any contributory factors, eyes, ears, nose, negative, 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 or some doctors you will find will write unremarkable, which means the same thing, nothing to write about. Okay. Mouth, tongue, pharynx, negative. Neck, no jugular venous distension or bruits, supple. That's important. Okay. Lymph nodes, negative in all groups examined at this time. Remember, your lymph nodes are in pockets around the body. Chest, dullness on the right side, 3/4 of the way up, clear on the left. So we have already established that he had right-sided pleural effusion. Remember, pleural lung, right? Pleural effusion is the passage of fluid through the tissues, okay? Cardiovascular, distant, S1 and S2, no murmurs, gallops, or rubs. That's a good thing. Abdomen, slightly obese. Who isn't? No masses or organomegaly. Okay. Genitalia, not inspected. Rectal, not inspected. Extremities, no clubbing or cyanosis. But he did have 21 pedal edema to the knee, slightly pitting. There were some superficial varicosities. Okay, so edema is excess fluid in the tissue, and that's what is visible as swelling. Okay, pitting is when the it's kind of like dimples caused within the swelling the swollen area. Okay. Skin dry, no rashes. That's good. Neuro, central nervous system intact, anxious. Totally understandable. And, you know, another thing is when you read something like this, regardless of your particular role on this healthcare team, and even as coders, you need to remember this. Who wouldn't be anxious? So it's very important that we use that to be able to remind us to be a little extra empathetic, a little extra caring, a little extra gentle if this patient comes to us with any questions about their coverage or their invoice or billing or whatever it might be. Okay. All right. And the last part of the patient record that we're reviewing today contains the information that you need. So now is the time to pull out that paper and pen and start taking notes, okay? Because as I said before, this patient record is going to require several codes. Remember, you are coding for the imaging department, and you might say, well, what did you make us go through the first 3 slides for when the 4th slide, this slide, is the only one that we really have to pay attention to? And that's because this is not the only one that you have to pay attention to. Remember, just because you might be focused on procedure coding for the imaging department, you still must report diagnosis code in the real world, not in this class, but in the real world and next term in your capstone. You will have to report the diagnosis code that reports the medical necessity for performing this imaging, these services, okay? Very, very important. So it is important for you to understand the entire situation with regard to this patient. And also remember that most of us do not know where you're going to end up working after you graduate. So you might, in this particular case, because we're talking about imaging, you might be able to go work for a freestanding imaging center and report imaging. In that case, it would be CPT. But the point is that this is our way of giving you experience in all of the different aspects of inpatient services so that you are primed and ready to sit in whatever chair you want for a job. Okay. All right. So Scott is getting a chest x-ray and they found large right-sided pleural effusion. Okay, and if you remember, this was part of the history of the present illness, the HPI, that said this, and now we have a chest x-ray to confirm it. So that will be one of the things that you need to report, will be the performance of taking this chest x-ray, okay? He also had a bone scan, because remember, he had bone metastasis. And 10-12 diffuse skeletal metastasis. Not good. Okay. But we have to now report and make sure we get our facility reimbursed for performing the bone scan. So we have a chest x-ray and a bone scan. And now we have laboratory data. Protime and PTT normal, platelet count normal, chemistry is unremarkable except for total protein of 5.8, albumin 2.6, total COT content 33, calcium 7.9, and alkali phosphatase of 210. Hemoglobin is at 10.6 with a white count of 10.1. Note, thoracentesis fluid from April 3rd, 2005, positive for malignant cells. Thoracentesis, you remember that this is removal of fluid from the thorax. This is your thorax, okay? Positive for malignant cells consistent with non-small cell carcinoma. Report now in this chart, part of the record. And if you remember, that also was mentioned earlier in this record. Okay, assessment, diagnosis as above, plan recommendations, tube thoracostomy, and after fluid is drained adequately of pleurodesis. Okay, so we do not code things that are recommended or planned. We don't know that the patient is ever going to have that. We only code after something is done. Okay, so first up, we have the chest x-ray. So B is the imaging section, B as in boy. W, anatomic regions. And remember, an x-ray is known in the professional circles as radiography. Now, here's something that's interesting. In CPT, X-rays are listed in the index under radiography, under R, okay? But they are described as X-rays. Oh, no, wait, I think I got that backwards. They are listed under X for X-ray, but they are referred to as radiography. Okay. All right. In PCS, the root operation term that we use is plain radiography. And that is to distinguish this from nuclear radiographs or any other type of radiography. Okay. And we have the chest X-ray, which would identify the body part, right, as chest. And when you look in your table, in your PCS table for BW0, you will see that you don't have to make any more decisions. But remember, you always have to put the placeholder. BW03 is not an acceptable PCS code. All PCS codes must have 7 characters. So even though the ZZZ doesn't report anything, that's why we call it a placeholder, you still have to report it. Okay? All right, any questions about coming up with this code for the chest X-ray?
No.
Great. Okay. All right. Now we have the bone scan, right? So we're going to go to imaging. Now a bone scan, obviously, skeletal system. And this particular part of the PCS section is divided by axial and what's the other part of the skeleton? What do you call these? Look in your book. Your book will tell you.
I'm sorry, I'm just kind of getting on this, Dr. Shelley. And I don't have my books with me because I'm not home yet. I'm at an appointment with my dad.
Okay, then I will tell you the answer. I'm going to go to it right now. And excuse me. All right, so we have BR. B.
And the thing is, I don't really have a problem. Like when I get to this right here, like I can do all this real good. It's just that sometimes when I come to the step of that, the encounter part, like all the stuff that you just showed together, I have to kind of take my time and kind of break it down to, you know, see what needs to be coded. As in the different with the review, how they break it down and say, what do you look into PCP? And you know how they break down what's the procedure.
PCP.
I'm talking about the procedure, like in the review, the last part of the review.
I don't know what you're talking about. I'm sorry.
That's okay. I wish I had it in front of me. I'm just saying the homework in the review. And the step, when I just get to the case problem, the case study, like without doing the step or without the step helping me, which I know I have to kind of work on that. I don't know what part that is, but it asks you, what's your first step? And you go to the ICD-10 PCS code, and then they say, what's your procedure? You kind of read the case study, and then you kind of go step by step of getting the full code.
Just like we were just doing. Yeah.
Right. And that kind of helped me, but I guess without it, I have to kind of, I get overwhelmed. I try to break it down to see what's needed to be coded, like in the encounter case study is kind of different from the review. So it's not really different, but I guess the review kind of help you step by step. I mean, I know if you're in the real world, you have to do it like the case study, the encounter. So that's why I'm kind of I need to kind of.
So you need help in abstracting the case studies to figure out what needs to be coded?
Yes. As where the review, I like the way it does it, what's the first step. And I guess I just have to kind of not get overwhelmed with the words, but kind of just read through take my time and read through it, which I do, but it still kind of throw me off. I guess I ain't gonna say frustrate me, but it's kind of,
Okay, are you using a medical dictionary?
I need to get one. I heard you on the last year recording, and I am ordering one of those. I know
Amazon has them for less than $10.
Yes, I found one for $6.
Perfect.
Yeah, I just ordered one. So
okay, make sure it's a medical dictionary, not a regular dictionary.
right, you're right.
Yeah. Okay.
I heard you on your last recording, and I was like, you know what? I did have one, but I guess I need a more updated one. I had a really old one from years, so I just got another one. I think I only paid $6.74 for it.
Excellent. Can't beat that, right?
No, it can't be that.
Right. And it will literally be invaluable to you. All right. If you email me and tell me that you need some more information about how to abstract the case studies,
Yes.
if you email me, I will send you something I wrote with lots of examples on how to abstract a case study. And it's got color and everything to help you pull out the words.
Okay.
Okay. And hopefully that will help you. And then, of course, ask me. And in a lot of cases, and I'm going to go right back here, okay, is in a lot of cases, it's going to be this blatant in looking at the case study. It's going to actually tell you this is what we did. Okay.
Right.
In other cases, though, as we've gone through surgical cases, it's a little more complicated. And it all depends on what the procedure is, what part of the body, and things like that.
Correct.
So this is it, and it does take patience. It does take skill. Oh, and you know what is I can tell you right now. Wait. See, this is what I love about being a coder. Because being a coder, you are never more than inches away from books, reference material. So you never have to worry about guessing or assuming. You will find everything within fingertip reach. Okay, in your coding book, in your textbook, not the coding manual, in the textbook, okay, right. Chapter 2 is focused solely on how to abstract clinical documentation. And okay. It will walk you through step by step. Okay? Okay. So I'm sure you already read it, but I want you to read it again. Okay.
I will.
And it's broken down to how to read it and looking for diagnosis code, information for diagnosis, and then separate for procedures.
Okay.
Okay. So read that. And if you have any questions, just email me and I'm happy to help you. Okay. And that plus the medical dictionary plus your coding manual is going to help you a great deal. Okay. All right. This is, yes, you were right what you said before. This is the job. This is the real job. You're going to read physician documentation, patient records, and you have to pull out the words that you need in order to configure the correct code. Now, right. Now, another thing that you can do that may help you as with PCS is create something like this, a table with 7 rows, okay? And put first character, second character, third character, fourth character, fifth character, sixth character, seventh character. And then as you're reading through the documentation, and what I would do is create a table with 7 rows in a Word document, and then just duplicate that and print it out. Okay. And then as you're reading, you can say, oh, look, imaging. Okay, this is going to be imaging. And then you have it to fill out 1 character at a time. And I think that will help you not only make sure to get all the information, but also kind of keep you focused. So you don't get all over the place. Okay. And it'll also help you. It'll also help you make sure you get all 7 characters. Okay. Another thing I want to tell you is as you're looking at the table, okay, so you got the first 3 characters from reading. Okay, that's set. You go to the table now, and this will tell you what information you need. This becomes a multiple choice question, tell you what information you need, and you can go back to the case study. You know, it's not like you have the case study and boom, you got to code it and you never get to look at the case study again. Go back and forth and back and forth and back and forth. Okay. Because again, sometimes you don't know what the answer is until you know what the question is. And the question may be different. Okay. For example, the difference between the imaging codes and the med-surg codes, okay, is we know that in the med-surg codes, the 5th character is an approach, but not in the imaging section, not in the measurement section, not in the mental health section. Okay, so that's the great thing about coding is you don't have to remember. And you know what? You don't want to rely on your memory. I know I've said this before, and that's because I love saying this. Unless you're Sheldon from The Big Bang Theory or Spencer Reed from Criminal Minds, you cannot possibly memorize everything. And the good news is, not only do you not have to memorize, we do not want you to memorize. Because what's written in the book is absolute accurate. And your brain may not, you know, right? You do that. It's like, oh, I remember that time we went out to the movies and I was wearing that red dress and your friend says, you weren't wearing a red dress when we went to the movies. You were wearing a navy blue, you know, top and pants. And oh yeah, I forgot. Right? Because we're human. That's the curse. Okay. So the good news is coders, we not only don't have to memorize, nobody wants you to memorize. The only thing I want you to remember is all the answers are in your coding manual.
Correct.
And how foolish is it to not use what is literally at your fingertips?
Right.
Okay. Does anybody know what the 3rd code is? The tracheobronchial bilateral X-ray. Oh, I love this. Okay. So let's see, where was this mentioned?
Oh no, yeah, I was just saying the body part.
Huh?
No, I was just saying, think about something you were just saying.
Oh, yeah. So in imaging, starts with a B like in boy, then tracheobronchial. See, this is why we made you take medical terminology before you came into coding, right? Trachea, bronchial, the bronchial trees in your lungs. Okay. Tracheobronchial right here. Okay. And guess what? You don't even have to guess because it's right there in the book, in the 4th character list. And we know is bilateral. So we go with tracheobronchial trees bilateral. Okay. Now to prepare you, in cases, there may be cases where the documentation says bilateral, but you don't have a bilateral choice in the table. You only have a right and a left.
So you split that. I mean, you go not split it, but go ahead. I'm gonna see what you're
Two
saying.
codes. Yeah, two
Yeah, two
codes.
codes. Right.
You code the left and the right
Yeah.
separately. Okay.
Mhm.
Now, just so you understand why, is in those cases, for whatever those procedures are, it means that almost the entire procedure has to be done again. Okay. So for example, if the physician did something for the hand, okay, let's say carpal tunnel release, okay, the patient has carpal tunnel syndrome, they're going to do a carpal tunnel release, and they're going to do both wrists at one session, okay. The doctor is going to write carpal tunnel release bilateral, all right, but as you can see, there's no connectivity here. So whatever has to be done on this side has to be done from scratch on this side. So you would report carpal tunnel release right, carpal tunnel release left. All right. And then that way you got everything covered. In those cases where you have a bilateral choice, you will only report one code because it already says we did it on both sides. And you can understand that because from the outside of the body into down the trachea, into the lungs, up to here, it's the exact same procedure. So you're already here, you make a right turn, you get the right, and they make a left turn, you get the left. So they join it together because it's not going to be twice the reimbursement because you're not doing totally twice the work. Does that make sense?
Mm-hmm.
You sure?
Yeah. I kind of, like I said, it's mostly when it comes to this right here, just me extracting the work in the case study. But usually I get pretty good with this. And then sometimes I really, with my condition, I really have to double check because sometimes I get excited and I'll put something and say, well, I knew it was that. What? So, yeah.
So why didn't you do it? Okay. So the biggest tips I can give you is number one, reread chapter 2 slowly and take notes. Okay. So you really get it in. If you have any questions, anything, you kind of go, huh? I want you to write that down and email me and I'll explain it to you. Okay. So number one, chapter 2, very important in your textbook on how to abstract medical documentation, because that's what we call it. Abstract is we pull out pieces of information that we need. Remember that the medical documentation is not written for us. It's written for continuity of care. It's written for lots of other purposes. And then we use it as medical coders also.
Okay.
So there's going to be information there that we don't care about. It has nothing to do with us.
Yeah. Now some I will get as you can see on my account, I will get one right and the other one wrong. So some just seem long. I may have to just take my time, which I do take my time. It's just that I have to I'll be all over the place, and when I have to read, I have to.
That's
really,
why, right? That's why I suggest make up these tables, print them out. So as you're reading the documentation, you can take your notes and fill it in. And then as you're building the code, and I totally understand, you always want to rush ahead, right? But in this case, accuracy is so much more important than time.
Right.
Okay. And the other thing I want you to do is when you get something wrong, when you get a code wrong on any of the homework or the quizzes or whatever, make sure you go back and you compare your code with the correct code and find out where you went astray. Is and now I understand. Okay, that makes sense. That's how you learn. That's how you will improve.
And maybe I'm doing something wrong too, because I'll be
Wait, you just cut out.
to
Hello?
the part, it won't pop up. Man, I'm gonna try it again. Maybe it's just something on my end I'm doing wrong. And I'll go back. Cause usually I do that like my last time I did that. Try so I was just off with this. And how did I get over there? So you're right about that.
Oh, yeah.
Yeah.
It happens to every single one of us.
So yeah.
Okay. All right. So
I'm getting ready to go in the back with my dad.
You're going where with your dad?
In the back. I'm at the doctor's office with him.
Oh, okay.
So
All
I'm
right.
going
Well,
to
I'm
see
just
if
done
they-
now. So just email me as I can help you and tell your
Okay.
dad we're with him. Whatever's
Okay.
happening. I don't know. It's
Yeah.
HIPAA, right? We can't.
Yes.
All right.
I'm coming. Okay, Miss Dr.
Bye.
Sheila, thank you so much.
Thank
And thank
you.
you for always emailing me back. I appreciate that. But trust me,
Always.
I will give you an email or call or whatever, however I can
Good.
get in touch with you to see what I need to get done. But I'm gonna do that.
Good.
And then I'll give you the updates on how to
Good.
go. All
Good.
right. Thank
All
you
right.
so much.
Bye.